All right, in this section, I'm going to go into how to perform a clinical evaluation of hypoglycemia, insulin resistance, all the way its way through diabetes, looking complications, and then autoimmune diabetes. So, one of the key things I really wanted to make sure we would do at the Karazian Institute is that I don't just give you a bunch of information about the research and have no application to it. So we always end all of our courses with a step-by-step clinical evaluation, taking all the information we presented into a clinical model and then actual treatment application. And these are just general frameworks to provide some type of guidance if this material is new to you. Obviously, every practitioner has expertise in different areas that they will add or do things differently, but at least it creates a structure of making sure that all the information presented it can be usable for you in some form into your practice. So far as we've gone through the course, we went into the pathophysiology of the web, we talked about diet, we talked about nutrition, we talked about nutraceuticals, we talked about environmental pathogens, and now we're really at the point where everything matters. So one walks into your office and you got to do an evaluation to see if they have a blood sugar disorder, what type it is, what's the severity of it, and what kind of objective markers you're going to look at to monitor their care as you develop some kind of treatment protocol. So the goal of this presentation is just clinical and really how to perform a step-by-step approach for hypoglycemia, autoimmune diabetes, and different patterns of hyperinsulinemia and diabetes. So this is kind of like the anchor chart, how to evaluate a patient with dysglycemia, starting with the initial clinical survey. You're gonna look at their anthropometric screen, kind of look at their body mass index. You're gonna do your medical history, and in your medical history, you're basically going to look at their chief complaint, see if that's a red flag for dysglycemia. Are there any predominantly hypoglycemia or insulin resistant or autoimmune diabetic patterns that are clear? So if you see someone, for example, that has been diagnosed with diabetes and they're underweight or normal weight, you immediately would suspect something like latent autoimmune diabetes of adulthood. What's the severity of the dysglycemia? And then some basic dietary history questions to go through the timeline. And then we'll talk about the physical exam. And this is where you can do anthropometric tests, general inspection, cardiovascular exam, eye exam, neurological exam, and diabetic foot exam. We're not going to go over an entire physical exam. We're just going to go over parts of the physical exam that are important as you identify dysglycemia. And then we'll get into laboratory tests that we'll discuss, routine laboratory tests and functional medicine lab tests. So we have a lot of information to go through. And remember, these are the three areas that we're going to focus on. Now, as a clinician, the minute someone walks into your office, you're going to determine if they have a pattern of hypoglycemia or insulin resistance as you go through their case. And then starting with the initial clinical survey is just how do they look? So typically, overweight people tend to be hyperglycemic, underweight people tend to be more on the hypoglycemic side. And when you look at their body mass index, your general clinical initial survey, you should be able to get a general idea. Now, just realize there are people that have an increased body mass index that do not have insulin resistance or metabolic syndrome or obesity because they have a really healthy diet. They're just not moving and they're not very active, and they have lots of healthy antioxidants in their diet. But for the most part, when you start to see changes in body mass index, you should always suspect some degree of hyperinsulinemia, hyperglycemia patterns. Now, clinical pearl, the more body fat an individual has, the more difficult it will be to turn around their insulin resistance. Remember that fat cells are really endocrine cells, and they release adipokines. And when people have obesity and hyperactive adipocytes, those adipokine releases promote inflammatory reactions, oxidative stress, that then promote insulin resistance throughout the body. So the greater body fat they have, the prognosis is going to be much more difficult if you're dealing with the hyperinsulinemia. And as you do initial clinical survey, you want to look at your patients that are more on the underweight side. And, patients that are underweight can be very complicated patients to manage. I mean, they can be really, really sick. Underweight patients can be very hard to manage. You must suspect an underlying disease or eating disorder. Now, one of the key things is everything we're applying in this course material is really null and void if someone has a psychological eating disorder. For some people, they just won't eat. You'll have patients that will refuse to eat fat and refuse to eat foods regularly, and they're hypoglycemic. And they may come in struggling with infertility. There's nothing you can do. In my practice, I just say, I don't have anything to offer you because the tools I need involve you following these guidelines. And you may need to find a different practitioner to work with you. Same thing with people that are hyperinsulinemia. If they're not deeply motivated to make some change, like if their spouse wants to bring their patient in, and by the way, it's always a red flag. Whenever you say like a spouse or wife goes, I want to bring my husband in, you should say, I really don't want to see your husband unless he comes in by himself. it's just going to set you up to be totally exhausted. It's going to change your relationship with your patient in an unhealthy way. If someone's not ready to be extremely motivated to make some change, these models of dysglycemia do not work. Everything we talk about this entire course is totally null and void if you don't have a highly compliant patient willing to make some efforts. So that is the key thing. So be aware of that and know that it's a factor whether a patient will respond to care or not. And really, if it's not going to work, just end it right there and then move on. Because if you don't, it's just going to totally deplete you as a practitioner, and you're not going to be there motivated to manage your other patients that are really ready to make some change. So these are the ones you're really worried about. The ones that are more in the obesity stage, the ones that are really underweight. These are the ones that'll have the worst prognosis. These are the ones that you really got to make sure don't have some kind of eating disorder and are motivated to make some change. And those that are underweight, you got to make sure they don't have any serious underlying diseases or malabsorption syndromes or things of that nature as well. Okay. Now, actually, my practice, my most difficult patients have really been the underweight patients more than, let's say, the overweight patients. Now, when you go through your medical history, there's some key things that you want to basically go through. Clinical Pearl, patients do not realize they have a blood sugar imbalance. You must know what chief complaints are associated with dysglycemia. So you got to know that anytime you hear a patient tells you that they have fatigue, especially if their energy levels change throughout the day or after meals, that there's a blood sugar issue, inability to stay asleep, inability to fall asleep, mood swings, anxiety, depression, hair thinning in females, hair loss in females are usually dysglycemia, not thyroid. Infertility is one of the main things that happens in females when they start to have dysglycemia. Well, we're going to talk about that in great detail in the next module. And then just any complaints about impaired metabolism, inability to weight gain or lose weight. Those are big issues. But the most important one is going to be changes in energy levels and fatigue. That will be your biggest clue. Now, the two main categories are hypoglycemia and insulin resistance. Remember, one of the key things we talked about is when you look at blood sugar levels, with all types of hypoglycemia, there's some degree of insulin resistance. With all types of insulin resistance, there's some degree of hypoglycemia. And one of the key things you want to do is when you identify a patient that has, for example, hypoglycemia, they may really come in with symptoms of fatigue, insomnia, depression, mood disorders, infertility, and you have to kind of work your way backwards and see if they also have symptoms of hypoglycemia, if they come in with these chief complaints like craving sweets throughout the day or getting irritable or shaky or lightheaded if they miss meals. And then you want to see if they have a diet and lifestyle that justifies that, or if they have diet and lifestyle that doesn't justify it and they're still hypoglycemic. With patients that have insulin resistance, they're going to come in usually complaining again of low energy, inability to lose weight, joint pain, just swelling, inflammation, again, infertility, hormone imbalances. And then you want to look at their history and see if they have any signs of insulin resistance, biggest one being fatigue after meals and sugar cravings throughout the day. And then you want to look at their diet and lifestyle and see if there's mechanisms that promote that pattern. Clinical Pearl, the most important clinical question to ask to determine if a patient has an underlying blood sugar imbalance. This is one of the things you should always ask in your medical history is, do you experience any change in your energy or function after you eat? So patients that are hypoglycemic, remember, they feel better after they eat. They feel like they can function again. Patients that are insulin resistant feel worse. They feel tired. They feel like they have to have coffee. That'll be your biggest clue. The normal response is to have no change in energy or fatigue after meals. Again, hypoglycemics feel better, and insulin resistance patients feel worse. Now, the other thing you want to do in your history that's very, very useful is to just start asking them about a basic dietary history and timeline. Key questions to ask, and you can print one of these schedules out where it has time of the day, starting in the morning all the way to nighttime. And this is, for example, I just downloaded this off a site that has free forms, but you can look at rising time, find out what they wake up, figure out what they're eating and at what time throughout the day. That's really, really important to identify dysglycemia patterns. So find out the rising time and bedtime and look at their food intake, figure out when they exercise, look for symptoms after meals, symptoms between meals, energy during the day, and sleep quality. In my practice, I do this timeline with these questions on every single patient. And it really helps you identify any type of blood sugar impairment and what kind of factors are involved with the blood sugar impairment. So let me give you some examples. So here's a typical dietary history of a hypoglycemic due to lifestyle. Let's say they get up, here it says 6 a.m., and the key thing really common with hypoglycemics that have lost their adrenal gland function or the cortisol awakening response, they have a difficult time getting out of bed. And then, for example, they start to have breakfast, and they note, they skip breakfast 2 to 3 times a week, just not hungry, they just skip it. So right away, that's a red flag for hypoglycemia. And then almond milk, if they do have breakfast, it's almond milk, fruit yogurt, and tea with honey. So there you see again, lots of sugar, very little protein, lots of simple sugars. And then they go in there and exercise and they work out. And then after their workout, let's say like around 10 o'clock, they have a nice fruit smoothie. And they do that, let's say 2 to 3 times a week. And then lunchtime comes around, they say they have something like with salad and chicken and vinegar. And they also say, sometimes, lunch can be as late as 2 o'clock or even skipped throughout the week. And then in the afternoon, they get sugar cravings, they have a snack. It's usually things like raisins, bananas, grapes, sometimes candy or gluten-free cookies. And then they have dinner like around 7 o'clock. And then after dinner, they usually get sugar cravings and have some popcorn or a sweet snack, and then they go to bed. That's a pretty common pattern you'll see with patients that have hypoglycemia. And, if you really look at this seems like a very healthy diet because you're eating fruit yogurt, you're eating fruit, you're having a smoothie, you're having chicken and veggies, you're having bananas. But really, when they're having rice, banana, and grapes in the middle of the day, that and no real significant protein or fat with that tends to cause blood sugar level drops. When they're waking up in the morning and having honey or fruit yogurt or skipping meals throughout the day or eating till 2 o'clock, then they'll have some symptoms. So if they have this kind of diet in combination with, they get irritable, shaky, lightheaded, they eat, they usually feel better, they function better, that's a clue to you that they're dealing with some type of hypoglycemia. Now, here's another scenario. This is a typical dietary history of a hypoglycemic patient that's not due to lifestyle. So you may have a person come in and tell you they get shaky, lightheaded, irritable throughout the day, and they tell you like they have to eat all throughout the day or they don't function. And you may even look at their labs and their glucose levels can be, let's say, less than 85, their fasting glucose. And here's the typical pattern. In this scenario, a person's saying that they wake up around 3 o'clock with increased heart rate and need to eat protein just to function. So they may wake up in the middle of the night and have to eat protein to go back to sleep. Then they usually wake up, their normal wake up time is around 7 o'clock. They wake up starving. They have to eat, and they have to eat something that's substantial. So they have bacon and eggs and maybe some piece of fruit. And then they notice like right around 10 o'clock, the blood sugar drops. So they might like make a steak, cut it in pieces, and then eat it throughout the day. So they're having a like ribeye steak. They have to do that at 10 o'clock. They have to do that again at 11 o'clock. And then around 2 o'clock, they have to have a really large, high protein meal, like a Cobb salad with eggs, ham, bacon. And if they don't do that, they crash. And then in the afternoon, they have to, for example, this person is having 4 hard-boiled eggs. And then at nighttime, they're having lots of high-fat foods with lots of vegetables. And they have to eat again another small dinner before they go to bed, or they just won't make it through the night. This is a person that has hypoglycemia that's probably due to some metabolic imbalance. So they can't regulate their blood sugar levels. And this is when we talk about the severity of hypoglycemia, this is the person that has something causing their hypoglycemia. Whether it's dysautonomia, whether it's some kind of insulinoma, whether it's some kind of pathology, whether it's adrenal autoimmunity, it's a totally different scenario. So this person requires greater depth of evaluation. So this is one of the things you want to pick up in your medical history. Here's another scenario. This is a history of a person, typical dietary history of insulin resistance due to lifestyle. So in this scenario, they wake up around 7:30. They wake up and need coffee to function. They have coffee with stevia and cream. They have a gluten-free toast with organic jam and butter. And then they have another coffee, stevia and cream. They're usually tired after they eat breakfast. They have to have another coffee. And then around 11 o'clock, they'll have some gluten-free pretzels, some trail mix, or maybe some chocolate chips, cookie with chocolate, with trail mix with chocolate chips. And then like 12 o'clock, they'll have a gluten-free pizza, iced tea with stevia. And then they get tired, so they have coffee again with stevia and cream. And then like 4 o'clock, they'll need some kind of snack. They'll have a gluten-free protein bar. And then they'll have like gluten-free fish or chicken with veggies. And remember, many of these gluten-free products are really high in the glycemic loads, right? So be aware of that. And then they may have, and again, 1 or 2 gluten-free cookies. So this is a person like had to go gluten-free for some reason, but eating gluten-free products all day, and these are just promoting high glycemic responses. This is like a typical pattern you would suspect some degree of insulin resistance. Now, here's a typical history of an insulin resistant patient that's not due to lifestyle. So they may have elevated, let's say in this scenario, the fasting blood glucose is 126 or higher, HbA1c is 6.9 or higher, and they wake up in the morning, have a green drink with no sugar or fruit in it, just a green drink, and then they, around 8 o'clock, and by the way, when they first wake up around 5:30, they do 90 minutes of exercise with cardio and weight training, then they have a green mixed drink as they're making breakfast, then they have 3 egg whites with mushrooms, and then around 11 o'clock, they have salad with chicken breasts and vinegar dressing. And then around 4 o'clock, they'll have some cucumbers and hummus. And then again, for dinner, they'll have fish and chicken and eggs. They go for an afternoon walk after dinner for 30 minutes, and they go to bedtime. If you saw this, and you saw the fasting blood glucose was high, HbA1c is high, that's the classic presentation of a latent autoimmune diabetes of adulthood. There's no reason for this person to be diabetic. This is where they have antibodies against their pancreatic islet cells. So these examples of going through the timeline can really help you figure out what's happening. So as you go through the timeline, you look at the time to wake up, time to go to bed, you haven't put in their diets, what they're eating at each meal, you gotta see if they have a pattern for one or the other. Now, if you see symptoms of hypoglycemia, and you see a diet and lifestyle that promotes it, then you start with the diet and lifestyle. If you see symptoms and lab work of hypoglycemia, and they have to eat every few hours, then there's some kind of metabolic underlying disease causing their hypoglycemia. And then if you see a person who's insulin resistant and they're eating lots of carbs and high sugary foods, that's pretty clear, and not exercising. But then if you see patients that have insulin resistance patterns in lab work and there's no indications for it, that's where you're thinking that they may have this whole autoimmune diabetes pattern. So those are very useful to you. So as you look at the timeline, you see how they feel, also ask them how they feel after they eat. Those are big clues to what's happening with their physiology. And then as you go through your initial survey and you go through your medical history, you're starting to really get a big clue of whether you suspect they have hypoglycemia, hyperglycemia, or autoimmune diabetes. And then the next part of your clinical goal is to go, okay, I kind of have to suspect what kind of blood sugar disorder they have, and then you're going to go through and try to rate the severity of it. And some of that can be very clear already from the history. Now, I'm going to tell you some stereotypes, generalization of people with dysglycemia. The person that comes in who's got like metabolic syndrome, that's overweight, they tend to always come in and say, I feel great. There's nothing wrong with me, but, and then they have infertility, fatigue after eating, depression, hair loss. Like they underplay what's happening. Just tends to happen all the time. And then patients that have like type 1 diabetes, they're really frustrated. They're coming in going, I don't know why I have diabetes. I don't know what's going on. Help me understand what happened. And then patients that are hypoglycemic, they usually come and say, I feel horrible all day and nobody knows why, because I'm so healthy, I eat so well, but I don't know why I'm sick and tired and fatigued all the time, my hair falls out and all this so forth. They feel like they're the world's biggest mystery, and they're really not. They're pretty straightforward. So those are some typical things that you might also notice in your practice. Now, once you go through and identify different types, you want to go through your individual workups. Let me start with the hypoglycemic because they're pretty easy and straightforward. So let's get that out of the way first. So when you're looking at hypoglycemia, remember we have different types of hypoglycemia. We have the functional hypoglycemia that doesn't really have any underlying disease, but they're just missing meals throughout the day. They're not stabilizing the blood sugar, and those people have fasting blood glucoses below the 85 range. Then you have your pathological hypoglycemics where their blood glucose is below the lab range and they have to eat every few hours just to function and stay normal. And those are the ones you're worried about when you look at the severity score. And remember with hypoglycemia, there's several things that happen with them. If their blood sugars are low throughout the day, they can't build enough glycogen throughout the day. So they get this nocturnal hypoglycemia. The key pattern being they have inability to stay asleep, anxiety or palpitations in the middle of the night. And then if you look at patients that have hypoglycemia, they don't get enough blood flow. And many of these patients that have hypoglycemia, if you're doing a history and exam with them, like halfway through it, they can like lose all function and you can actually see them fatigue. You can see that look of fatigue on their face and they just want to lie down and they really can't answer your questions anymore. They have poor brain endurance issues. So they might start to complain. You might just see them irritable, mood swings drop, depression. They may even bring their own snacks because they know that's going to happen. And they in the middle of the history exam, they go, hey, do you mind if I have a snack? And those are clues to you that their blood sugar is very low. And as they decrease blood flow to the brain and to their tissues, cold hands, cold feet, they really may compare hair falling out, unhealthy nails. That's chief complaints. And then as you look at their alpha cells, of the pancreas not releasing glucagon well. They have chronic blood sugar cravings, crash in the afternoon, must eat frequently to maintain their function. And if their electrolytes become imbalanced, they get muscle swelling, muscle cramps, body swelling. They might tell you sometimes the body just swells. They constantly crave salt. They have to constantly fight to stay hydrated. Muscles get tight all the time. Those are all the key things you'll see. And then if the adrenal glands start to get depleted, they can't really handle stress very well. They're unable to work out. They get really exhausted very quickly, constantly having sugar anxiety. Those are the typical patterns of the physiological web of hypoglycemia. Now, so that's what you're going to see as their chief complaints, their presentation, when they come into your office. And then as you do the timeline, you'll kind of figure out if it's really due to their diet and lifestyle or secondary to something else. Some key things you're going to see with an exam with hypoglycemics, well, again, they'll be on the normal or underweight side with their anthropometric test, but they'll have some very key findings that's involved with this. So remember, with these hypoglycemia patterns, there's some things going on here. They have loss of pancreatic alpha cell resiliency, meaning that when when blood sugar levels drop, your pancreatic alpha cells, the pancreatic alpha cells have to release glucagon to get the levels back up, but constantly having blood sugar spikes and crashes all throughout the day with simple sugars and missing meals really puts a lot of strain over them, and over a period of time they just become less efficient, and they're more prone to having the blood sugar levels become low. And then since they don't have enough glucose in their diet, food in their diet, of missed meals and quickly simple sugars, they don't have enough glycogen, so they don't have the reserve fuel when their blood sugar levels drop. So it's not uncommon to see their serum glucose levels drop quickly, the brain endurance goes down, so they have cognitive impairment when blood sugar levels are low. They may tell you that. They say, I cannot think after 2 o'clock. I can't function at work after 2 o'clock. I can't function. I'm okay in the morning, but then the day hits, I get worse and worse, and then I really can't do much. Some days I'm even tired just to drive home. Those are typical things you'll see with hypoglycemic. And then these chronic blood sugar shifts help cause some loss of adrenaline resiliency. It's not a disease, but just some physiological issues. The aldosterone and catecholamine levels are compromised. They're not as efficient. Typically, you'll see low blood pressure with the hypoglycemic patients. And since their blood pressure is low, they can't get healthy circulation and tissue perfusion. So they'll have cold extremities, pale nail beds, poor capillary refill time, hair thinning, unhealthy nails. One of the most common complaints with patients that have hypoglycemia is actually hair thinning and hair loss. And this is just really caused from lack of blood flow to the brain. And you usually see, and as the circulation improves, as the blood pressure improves, their hair comes back. So, this type of hair thinning is related to it. A lot of times, just when you see a hypoglycemic patient come in with really low blood pressure, really low perfusion, just touch their fingertips, compare it to the rest of their arm. If their fingertips are really cold, their toes are really cold, touch their nose. If the tip of the nose is really cold, those are all signs that they're not getting healthy amounts of blood flow and circulation to their distal tissues. The scalp is a distal tissue, and hair follicles need blood, which carries hormones and growth factors and nutrients to allow them to function properly. And when there's poor circulation, one of the side effects is this hair thinning and hair loss. So a lot of hypoglycemics will come into your office and they're bewildered. They've seen everyone in the world. They don't know why they're losing hair. Thyroid's been checked 100 times. They don't know why they're having this problem. And they've gone to all these different specialists. And ultimately, it's their hypoglycemia pattern that they just constantly ignored because they really think they're eating healthy and well, and they're really not. You also see signs of poor circulation. You'll see these pale nail beds, weak nails, and these lines and all these things happen when there's not enough nutrients and oxygen and blood flow to the nails. You may see fungal nail overgrowths because they can't get through perfusion to their toes to carry immune cells, so they're prone to getting fungal overgrowths when they wear their socks. If you touch their hands, they usually seem to be very cold. A lot of times they'll just touch you and go, my hands are always cold, and put it on your face for whatever reason. It makes you jump out of the table because they're freezing, and they're bewildered why that's happening, and maybe this is just related to hypoglycemia. You can check your capillary refill time. Here's just a quick exam how to do the capillary refill time if you're not familiar with it. You basically push on the distal digit, and you want to see color return under 2 seconds.
For the capillary refill test, apply pressure to the distal volar portion of the digit until the tissue turns pale. Once the tissues turn pale, simply release and count the number of seconds it takes for the color to return to normal. One more time. A negative result, or a normal result, is when color returns to normal in 2 seconds or less. This was a negative or normal result. A positive result would be if it takes more than 2 seconds for color to return to normal after the pressure is released.
Okay, so the other key thing you'll see with hypoglycemic patients is their blood pressure tends to be on the low side of low normal or even just hypotensive altogether. So you'll see ranges of the systolic in the 90 or below range, and diastolic, somewhere, 60, even lower than 60 range. And those are indications that they don't have poor perfusion well. So ideal blood pressure for them is 120 over 80. You want to get it to 120 over 80. Some of these patients have hypoglycemia, especially with the hair thinning, hair loss. You say, listen, when your hands and feet are no longer cold, your blood pressure goes up, your capillary refill time's improved. Let's have this discussion again. And in the meantime, let's really just get your blood sugar stabilized, get a chance for your adrenal glands to recover, and go from there. So those are the things you'll see in the examination with people that have hypoglycemia. Remember, when they have hypoglycemia, you have different degrees of severity. You may have already picked up on what degree of severity they have from the medical history, because if you identify symptoms of hypoglycemia and then you see that their diet doesn't justify why they're hypoglycemic because they're eating lots of protein all throughout the day and they're not eating sugar and not letting the blood sugar levels drop, then you suspect that they may have hypoglycemia due to underlying metabolic imbalances or due to disease. If their diet justifies it, then it's more of a functional hypoglycemia. The lab pattern you'll see with functional hypoglycemia is really glucose less than 85, LDH less than 140, symptoms of low blood sugar throughout the day, diet and lifestyle that promotes blood sugar drops. And that's an example of the dietary history where they're just missing meals or having simple sugars throughout the day. When you look at lab work, glucose levels less than 85 is within most labs' normal reference range. But if you see glucose less than 85, you'll typically see shakiness, lightheaded, irritability, that they feel better after they eat. So this is a functional range that's pretty good. And then you'll also see that LDH, which is used to synthesize pyruvate to lactate and back from lactate to pyruvate, is decreased, and levels below LDH below 140 are also suggestive of these hypoglycemia patterns. Now, when people have chronic hypoglycemia, basically what it means is that their counter-regulatory responses to a low blood sugar state are not working well. And, one of the key things is the pancreas has alpha cells that release glucagon. Well, you can get alpha cell depletion. So patients and even diabetics, they actually have their alpha cells get depleted just like beta cells get depleted and fail over time. If someone has been hypoglycemic for the last 30 years, 40 years of their life, their alpha cells just don't work very well. And they have this tendency to be hypoglycemic for the rest of their life. And they have to just maintain a diet and lifestyle to manage their hypoglycemia. Adrenal function can get taxed with people that have chronic hypoglycemia patterns. So right away, as soon as you see someone has functional hypoglycemia patterns, you're looking at some of these counter-regulatory pathways that are not working well that would normally will help them get their blood sugar levels back up to normal. Now, loss of resiliency to recover from drops in blood sugar, the key things with them is if they don't have enough glycogen reserve. So one of the key things of being hypoglycemic and not eating frequently enough is you just don't build enough glycogen. So remember, glucose is used for energy, and then part of your dietary intake of glucose gets stored as glycogen. And if there's not enough glycogen reserves, there's inability to raise glucose levels. This typically shows up when people are asleep, because that's really when they're counting on their glycogen reserves. And if they don't have enough glycogen to last them through the night, they usually wake up in the middle of the night with their heart rate going up and anxiety, because they have to then activate epinephrine, norepinephrine, to break down protein through the gluconeogenesis pathways. Adrenal medulla insufficiency and releasing catecholamines, that can impact raising glucose levels. Adrenal cortex insufficiency releasing cortisol, that can be a factor. And then some people eat simple sugars all day, like honey and fruit all day, and they actually get some degree of insulin receptor site hypersensitivity. And when they eat something that's sugary, they have a postprandial hypoglycemic event because they just pump out so much insulin, and that promotes their hypoglycemia as well. So that's why it's important to cut down on their high sugary based foods, and you can have one or more of these combinations. Now, the laboratory test for functional hypoglycemia, fasting glucose, less than 85, LDH less than 140. You might want to do a lipid panel just for their general health. You might want to do a comprehensive chem panel, make sure there's no underlying imbalances or anything that's abnormal. And for some people, you may not even catch hypoglycemia unless you do what's called the glucose insulin response test. And some labs may have a different name for the same test. This is the name that LabCorp uses this is just the lab that's the most common, the biggest lab in the US. But this is where they measure glucose and insulin at baseline, 1 hour later, and then 2 hours later. And sometimes you won't see their hypoglycemia unless you test glucose levels that way. And one of the most important functional medicine tests to do with people that have hypoglycemia is to do an adrenal stress profile with the cortisol awakening response. So you can see if they have adequate function there. Now with this adrenal salivary index, this is the one through Genova, they'll measure what's called a cortisol awakening response, and cortisol levels should have a 50% increase from the minute they open their eyes to the first 30 minutes. And then cortisol levels should be high in the morning and eventually go down throughout the day. So you want to see if they have a proper cortisol awakening response and if their cortisol levels are functioning well. And cortisol is critical for the counter-regulatory measurements to bring blood sugar levels back up. So cortisol is involved with glycogenolysis to break down glycogen to use as glucose and to really impact their hypoglycemic state. So when you look at adrenal imbalances, just know that there's two types. There's the cortisol shift in which you're dealing with the response to blood sugar drops after the first 5 minutes. And then you have the adrenal medulla, which is the immediate response, which is more autonomic. Let's talk about this pattern first. So people that have symptoms of normal adrenal medulla responses but abnormal cortisol responses, they get irritable when the blood sugar levels drop, this so-called hangry, blurred vision, poor focus, concentration, jittery, and then you can see different types of imbalances with the cortisol rhythms. Now, elevated cortisol patterns can sometimes happen as a compensation for their chronic hypoglycemia throughout the day. Low cortisol patterns can happen because they're just not able to produce cortisol anymore, or they could have disrupted rhythms from the roller coaster ride all throughout the day, or they're abnormal. They may have an abnormal cortisol awakening response where they can't get that cortisol up in the morning like they should. So any of those possibilities are associated with hypoglycemia. So here you see a typical cortisol rhythm. So they wake up, and the first thing you see is within that first 30 minutes, this is called the cortisol awakening response. So cortisol levels should go up about 50% from when they wake up to the first 30 minutes. That's a normal physiological response. Many patients that have hypoglycemia, blood sugar disorders, don't have a healthy response here. And this is the patient that cannot function, cannot get out of bed, stays in bed forever, staring at the ceiling, keeps pushing snooze, has to get coffee to even function. I mean, there's a difference between drinking coffee or tea in the morning because you enjoy it, or having to do it even though you don't like it because you need to function. So this is the cortisol awakening response, okay? And some people that are really have strong willpower, they'll have to do exercise in the morning or they don't function throughout the rest of the day. And those are also people that usually have impaired cortisol awakening responses. Then cortisol levels, usually go down throughout the day and reach the lowest levels at bedtime. And you can have different patterns. So high cortisol patterns, you'll see all the time with hypoglycemics because they're constantly having their blood sugar levels drop throughout the day. And this lets you know that their adrenal glands have some degree of resiliency and function, and they can keep their blood sugar levels up, but you'll see high cortisol with many hypoglycemics. Whatever their baseline is what you want to normalize. So these red line of the cortisol output should be, in a rhythm like this. You can have some people that have a disrupted rhythm, the cortisol levels all over the place, but that are hypoglycemic. You can have what we call flatliners. They just don't produce cortisol throughout the day. And then you can have people that have normal rhythms, but they don't have a proper cortisol awakening response. They don't get that 50% output. So those are all things that you want to measure as a baseline. And as their blood sugar gets more stable, as you provide nutraceuticals to support their blood sugar stability, you should see these abnormal cortisol profiles improve. But any of those four patterns are possible with people that are chronically hypoglycemic. And these are things you definitely want to check with people that have functional hypoglycemia. Now, as you go down the severity scale, people that have functional hypoglycemia due to underlying metabolic imbalances, they may have fasting glucose below 85 and below 85 and LDH below 140. There's symptoms of low blood sugars throughout the day, but they have constant consumption of high-fat, high-protein meals throughout the day to function normally, but they're still not in the laboratory pathological range of low blood sugar. And those are the ones where you see, like the example I gave you, where they're just eating protein all throughout the day to function. Those are people that if their blood glucose is in the physio-functional range of less than 85, but within the normal laboratory reference range, not below, let's say, 65, you suspect they may have some underlying metabolic imbalances. So They could have pancreatic alpha cell depletion. Like I was saying before, chronically hypoglycemic lifestyle over a period of time does deplete alpha cells, just like chronic insulin resistance depletes beta cells. They could have subtle adrenal autoimmunity. This is not uncommon. On the Cyrix Array 5 test, which we talked about in the autoimmune course, there's a marker called 21-hydroxylase, and you can order with any laboratory 21-hydroxylase, and that's an antibody marker for adrenal autoimmunity. And many people have some degree of adrenal autoimmune reactions that cause them to lose their resiliency to get their blood sugar back to normal. And usually they have low blood pressure and they feel like they're a chronic adrenal fatigue patient for their whole life and a chronic hypoglycemic patient, but they really have this underlying adrenal autoimmunity. And, just note that the laboratory markers that they use to identify adrenal autoimmunity called Addison's disease, like 24-hour urinary corticosteroids, and symptoms of Addison's disease don't appear until they lose 90% of their adrenal glands. So you can have patients that have autoimmunity and they've lost less than 90% of their adrenal glands, maybe 50% of the adrenal glands, and they have all the symptoms of chronic hypoglycemia, and they have to constantly eat protein throughout the day to function. And those patients are not uncommon. So 21-hydroxylase is the target protein for adrenal autoimmunity. There's also adrenal protein antibodies, but here's 21-hydroxylase. 21-hydroxylase is right here. It helps convert precursor cholesterol and eventually progesterone into actual cortisol, aldosterone. So the antibody response is right here. So they can't produce cortisol. So they don't have the resiliency to get their blood sugar levels back up when their blood sugar levels drop. So you definitely want to check for that, especially if the patient that you're seeing has chronic hypoglycemia and their diet and lifestyle doesn't justify it, has another autoimmune disease like Hashimoto's or rheumatoid arthritis, for example. Now, the symptoms and signs of adrenal autoimmunity are very similar to hypoglycemia, fatigue, extreme muscle weakness, salt cravings all throughout the day, loss of appetite, low blood pressure, signs of dehydration, orthostatic hypotension. So when they stand up, the blood sugar levels drop. And if it gets really progressed, they can get hyperpigmentation of their skin. And then these are the laboratory findings as well. Okay, now the clinical strategies for adrenal autoimmunity is if you see symptoms, just monitor them over time and see if they get worse, and maybe at some point they get progressed enough where they may need corticosteroids, but this is pretty uncommon. Most people have adrenal autoimmunity, never really get to the 90th percentile where they have Addison's disease. Another key factor why people can be hypoglycemic and have metabolic factors that are causing it is subtle liver diseases, biggest cause being chronic hepatitis C. So be aware of those. You can see some of these clinical findings like liver pain or easily bruising, spider angiomas, palmarrhythmia, telangiectasia. With jaundice is pretty rare unless it gets really progressed, but those are things you want to be aware of when you're seeing a hypoglycemic that doesn't make sense. Anemia is a key factor. So, look for paleness of their skin. When people are anemic, if you check the respiratory rate's really high because they're trying to get oxygen. Their red blood cells aren't carrying oxygen, so the respiratory rate and even their heart rate are pretty high as a consequence of the anemia. And then they could just have, significant mitochondrial uncoupling from free radical pathology, like underlying cancer or underlying infections or something that's more serious. And even there's people that have hypoglycemia patterns that are due to traumatic brain injury, and they get dysautonomia patterns. So dysautonomia is when the sympathetic system is dysfunctioning. It's not properly responding. When blood sugar levels initially drop, the autonomic nervous system, the sympathetic system has to really kick in to make things work. So dilated pupils, pulsating pupils, extreme sensitivity to light, to pin light, abnormal heart rate variability. These are all signs of dysautonomia. If you remember the neuroinflammation course, Matthias, who shared his case with us, he had basically dysautonomia. He had a traumatic brain injury and he couldn't keep his blood sugar stable, and he would wake up every 2 or 3 hours to function well. So he was the hypoglycemic that really had an underlying pattern due to dysautonomia. So he had all the symptoms of hypoglycemia, but when you look at his diet, he was eating frequently throughout the day. He had to do that to function, and the underlying cause of that was the traumatic brain injury. So what happens with dysautonomia is there's injury to brain centers, there's dysautonomia, there's ability to dampen sympathetic responses, heart rate levels go up, there's drops in blood sugar, and you get a hypoglycemic response. So clinical pearl, whenever a patient has significant inappropriate sympathetic reactions associated with hypoglycemia, suspect brain-based dysautonomia, and especially if a patient comes in already telling you they have things like POTS or or things like MSA or any of these other chief complaints, you suspect dysautonomia. So remember that the brain controls these autonomic centers, and the key finding that the adrenal medulla is not able to work well is when the patient's blood sugar levels drop, they get immediate anxiety. They get immediate heart rate changes. They start to get physiological tremor where their blood sugar levels drop. Those are clues to you that it's not an adrenal cortex issue, but adrenal medulla. The initial 5 minutes of getting blood sugar levels back is all related to the adrenal medulla. Now, when you're looking for laboratory screens for hypoglycemia, you look at fasting glucose, fasting insulin, do a comprehensive blood chemistry panel. You can even look at things like ESR, C-reactive protein, lipid, albumin, C-test. And this is just a list of things to evaluate. You can even look at the adrenal antibodies to see if everything's okay, but these are your diagnostic screens. And if you do these tests and you find no abnormality, all that tests are normal. Make sure there isn't medication-induced hypoglycemia. Make sure they're not having nutraceuticals that cut down their blood sugar, like berberine. Some people use it for bacterial infections, but also, as you know, drops blood sugar levels. And then make sure they don't have dysautonomia. Dysautonomia can be from traumatic brain injury or progressed neurodegenerative disease. And then if you do all the lab tests and you see that they constantly eat protein and function throughout the day, this was a list of conditions to rule out that may be associated with pathology. Okay. So those are the key ways to work up and evaluate a hypoglycemic patient. Let's move into autoimmune diabetes. And for autoimmune diabetes, a patient that's normal weight or underweight and they have diabetes is your biggest red flag that they may have an autoimmune process. These are the target antibodies that you want to screen for. ICA, also known as islet cell antibodies, GAT65, ZN28, and if they progress, they can start to make antibodies against their own insulin. So the more antibodies that show up, the more likely the diagnosis, but any one of them alone is enough to diagnose type 1 diabetes. And when you look at the autoimmune diabetes web, once they make antibodies to these target proteins, they usually have associations with other autoimmune target proteins. So when these levels of antibodies show up against their pancreas, you always want to check C-peptide. C-peptide is a reflection of how much insulin they can make, and that'll give you a clue of what the integrity of those beta cells are that's left over. And then if their GAT65 is expressing in their brain, they can get anxiety, dysautonomias, hyperkinetic movement disorders. If they also have transglutaminase 6, they can get vertigo, dizziness, dysautonomias. 2, they can get villus atrophy, malabsorption syndromes, and transglutaminase 3, they can get autoimmune dermatitis. And eventually, if they start to react against their insulin, then you get an exogenous insulin autoimmune pattern as well. Now, you should also know that there are people that have overweight patterns and still have autoimmune diabetes, but you definitely want to suspect that it's really your normal underweight patients. Here's some commonly known athletes that have type 1 diabetes: Halle Berry, Nick Jonas, Chris Freeman. These are people that still function very well with their autoimmunity, but these are the type of things that would be an immediate red flag for you. If a person that looked healthy like these individuals walked in and have diabetes, that would be screaming to you like for autoimmune diabetes. And if you're doing Array 5, which is just a quick screen for autoimmunity, they check islet cell antigen antibody, which is a very good screen in GAT65. These two are the most common antibodies that show up with autoimmune diabetes, whether it's type 1 or latent autoimmune diabetes adulthood, and you can also screen for adrenal autoimmunity on that panel as well. And the key thing with them is that when these antibodies take place with GAT65, GAT is involved with the insulin release, and islet cells are directly against the alpha and beta cells. So they can also get periods of hypoglycemia with their autoimmunity, and they have this roller coaster ride, not just hyperglycemia. Then eventually they can attack their own insulin. And then this is a chart that just goes over the signs and symptoms: fatigue after meals, weight gain or weight loss. Weight loss is a big one: polyuria, polydipsia, increased appetite. Lab findings: increasing fasting glucose, elevated HbA1c. The autoimmunity itself causes glycation, and then fructosamine level elevations and triglyceride level elevations as well. Now, the clinical strategies for silent pancreatic autoimmunity is, you really want to monitor them over time and make sure they don't get to the point where they really require insulin, or even they may even get to the point where natural medicine and lifestyle doesn't work so well, and they may need some medication or exogenous insulin to control their symptoms. This is a chart I made for you that just goes into, we talked about this in the autoimmune course, and unfortunately we don't have time to go over all those, but these are the things that are triggers for autoimmunity. And I'm not going to go over this list because we just don't have time in this course to review everything we taught in the autoimmune course. But, like with anything, you want to find what stage of autoimmunity they have, whether autoimmunities exist, dietary protein triggers, chemical triggers, lifestyle triggers, if the barriers are intact, how to improve their immune system tolerance, and so forth. And then you want to look for viruses that are associated with type 1 with diabetes, and you can test with those. And one of the key things we talked about was looking for, with patients that have type 1 diabetes, specific cross-reactive foods. So if you find out what type of autoantibody they have for type 1, and you do something, let's say, like a Cyrex or A10 to look at food antibodies, you can then match that up with the paper we published on cross-reactive food for these specific antibodies. So you need all three of these steps involved. And then whichever foods that they actually have antibodies for that are also on this list, you would want to remove to reduce cross-reactive potentials with their foods. So here's the list for GAT65, GAT67, IA2, ZN28, and that's pretty important when you're looking at the evaluation of triggers for type 1. Now, as we get into autoimmune diabetes, let's shift into the hyperinsulinemia, insulin resistance pattern. And so for these individuals, remember, they go down this negative spiral from just the postprandial glucose response, insulin resistance, to metabolic syndrome, to diabetes, and then diabetes with HbA1c elevations, and then with complications and nephropathy. And when you're looking at the timeline, remember, from when someone starts to develop insulin resistance to go down that downward spiral, it could take 15 years before they get into type 2. They have blood sugar instability and they don't manage the type 2 very well. Within 10 to 20 years, they can have beta cell failure and then become insulin dependent. And along these years, they have, typically these most common chief complaints. As you look at the workup, you have to kind of figure out the severity of the scale. So you can look at blood glucose levels and HbA1c levels and to determine how severe the condition is. For the scale of hyperglycemia, you can't just pick it up from symptoms. You're going to have to do some lab work, especially fasting glucose and HbA1c, to see where things are. And then once you identify what part of the scale they are, you can look at the vicious cycle, and not to repeat the physiological webs, but as you know, these physiological webs of excess insulin will cause endocrine imbalances, intestinal permeability, hormone imbalances, brain fog, brain inflammation, and really cause systemic inflammation. They can alter the lipid panel, which you'll start to see as they start to develop metabolic syndrome. And then if their HbA1c levels come up, that's where you start to get vascular injury and renal injury and damage to the retina and damage to neurons, and as they progress down the scale. Now, the laboratory tests you definitely want to evaluate metabolic syndrome or diabetes, the most common ones and most important ones are fasting glucose, HbA1c. This is a 3 to 4, 6 to 8 week window of blood sugar glycation. Fructosamine is a 2 to 4 week window, 1 to 2 week window of glycation. Glycomark, we'll talk about that a little bit later. It tells you glycemic spikes. You may want to even look at their postprandial insulin and glucose response over a 2-hour period to get a general idea. You should always get a comprehensive metabolic panel to make sure they don't have any signs of complications, kidney disease, liver disease that's working. Lipid panel to get an idea of what's happening with their shifts in their triglycerides and HDL and cholesterol. CBC, make sure their immune function is healthy, make sure they don't have anemia. C-peptide is a window to reflect how much insulin production can take place with the pancreatic, and then markers for inflammation. And the functional medicine test, do you want to consider with people that have insulin resistance, can also be the adrenal stress profile. And then if you want to look at chemicals that are diabetogens, obesogens, endocrine receptors, you can look at glyphosates and toxic non-medical chemicals. And then you can also look at the comprehensive stool analysis to get an idea of their microbiome. Now, the physical exam for these patients, here's a chart that goes into, all the key things that can be involved with the diabetic patient. Let me just go over the key features. When you're doing your exam for insulin resistance, you want to start with anthropometric exam. And that's basically body weight, height, body mass index, waist to hip ratio. And usually you'll see these with the hyperglycemia patients, overweight patients. So once you calculate their height and weight, you can easily calculate the body mass index. And then you can take a tape measure and do their waist to hip ratio. And then you can keep that as a baseline to see how they do. So for example, if they are going to do intermittent fasting or do a ketogenic diet, you may see some big changes in those. And then there's a chart to determine their risk factors and where they stand with their waist to hip ratio or body mass index. And that is important to kind of get a baseline measurement for them. Now, the other key things to do when you're doing your exam is just your general inspection. And one of the key things you'll see is skin tags, orocordones, acanthitis nigrans, androgenic alopecia. These are common things you'll see with insulin resistance. The skin tags you may see all the time with patients that have insulin resistance. And these skin tags go away as you control their insulin. So sometimes when you see, when you're doing the exam, you see lots of skin tags everywhere, you should definitely suspect insulin resistance. And if they have skin tags, as you control their condition and get their insulin and blood sugar levels down with diet and lifestyle, you should see these skin tags go away. Not all of them, but it's significant change in them as the system improves. With people that have significantly elevated glucose and insulin for a long period of time and high degrees of hyperinsulinemia, what you can actually happen is you can have some changing of their skin where they have this brown to black, poorly defined hyperpigmentation of their skin. So you can see that like here in the neck. You'll see this with diabetic with high amounts of insulin. Here you can see it around the lips. Some people like behind the neck fold or even on their skin. Whenever you see these acanthos nigricans skin markers, these black markers, you know you're dealing with a patient that has significant amounts of hyperinsulinemia. And then one of the key things you'll see with especially with females is they get what's called androgenic alopecia, which is like male pattern baldness in a female. It's not hair thinning, but you'll start to see like the front of their scalp start to lose hair. That's a major sign that they have increased insulin issues that are causing androgens, especially in females. Here's like female pattern baldness. Hair thinning can take place. You'll see this with a lot of hypoglycemics. With females that have a lot of insulin resistance, you'll start to see this male pattern balding. That's there. That's an androgenic issue. And if you see that, you're probably going to have abnormal cycles and infertility patterns as well, because usually the high testosterone will disrupt their female feedback loops, FSH and LH feedback loops. And then there's another condition called necrobiosis lipiditica, which is just a granulomatous skin infection, inflammatory response in their skin. You'll see those with uncontrolled cholesterol and insulin levels. And with people that have really high lipid markers from their dysinsulinemia, dysinsulinism, hyperinsulinemia, you'll see these little fat buildups over their eyes. Those are clues to you that their lipid panel is totally abnormal. These aren't always blood sugar. They can happen with some genetic cholesterol metabolism disorders, but they're not uncommon to see with patients that have metabolic syndrome, diabetes with abnormal lipid markers. And then when you're going through your workup, you realize that people that have diabetes are at significant risk for metabolic issues. So you definitely want to look at their blood pressure. People with metabolic syndrome, insulin resistance, have a tendency to have hypertension because insulin activates sodium retention, so they get increased blood pressure responses. And you want to look at their heart rate. Increasing resting heart rate greater than 85 is typically found with diabetes and tells you that they have a significant mortality risk. And another key thing you can do is the ankle brachial index. Ankle brachial index is you check their blood pressure in their arm compared to the blood pressure in their legs. Anything below 0.9 means they have some type of early vascular peripheral arterial disease. They're not getting blood flow through their extremities very well. So that's also another important test you can do in your office. And then you definitely want to look in the eyes of your diabetic patients. Cataracts are very common in diabetes. So you can see the occluded lens. In this image here, you can see this occluded lens. So hyperinsulinemia promotes mechanisms that then lead to dysfunction in the lens, and it causes that cloudy appearance, and they end up with those physiological expressions of cataracts. And then if they have high blood pressure and they have uncontrolled diabetes, you can actually, if you look at their eyes, make sure they don't have these diabetic retinopathy patterns. And if they do, they should definitely be co-managed or managed at some degree with an ophthalmologist to maintain their eye health. And then you want to look at your neurological exam. And one of the key things that happens with diabetic patients And patients that have metabolic syndrome, especially when the blood pressure is high, is they get cerebral small vessel disease. They get tiny mini strokes all over the place. And they may at times complain that they're slurring their speech. They may complain at times they have lost a certain function, and then the function may come back. So whether the function is like all of a sudden the right arm doesn't work as well, it's a little bit heavy. Other times it's all cognitive. They can't think, they can't focus. Sometimes we do an MRI, they'll just see these patterns of microvascular disease all over the brain. So be aware of that. That does happen with many diabetic patients. It's also really common for these microvascular diseases to impact areas of the brainstem, controlling eye movement. So you can get palsies of the cranial nerves 3, 4, and 6, where they start to get double vision. So anytime a patient starts to tell you that they have episodes of getting some double vision when they look to the left or look to the right, they may have had a little mini stroke. It's not uncommon in diabetic patients. And then many diabetic patients, as they continue to progress, they'll actually have accelerated neurodegeneration unrelated to the microvascular disease just from insulin promoting beta amyloid plaquing. And you might see some of these cognitive effects decline, like attention, memory, learning, problem solving, their motor speed, their vocabulary. These will be pretty clear for you in your history. And you always want to look at every diabetic patient and see where they are in the dementia scale. So remember, there's 7 stages of dementia. And usually when they start to get to stage 4, stage 3, they really know something's wrong. They can't remember things. They have to write everything down. Once you get to stage 4, that's when they get help. That's when their family members driving you to the office. That's when their family members helping you with their history. That's when they have to write everything down or they'll forget it. That's the patient that calls you and asks you to repeat everything to them that you just told them because they can't remember. So there is some early signs of dementia with people that have diabetes. You always want to do a pretty good foot examination with anyone who's diabetic. You're always worried about, number one cause of amputations is diabetes. Number one cause of blindness, by the way, is diabetes. So you want to look at their foot, make sure that they're not getting any of these diabetic foot ulcers and they have proper foot care. And usually when they get progressed to the point of diabetes like this, they're already working with a specialist that's managing their blood sugars and so forth. But you always want to, make sure. There are a lot of people out there that just don't go to conventional medical doctors anymore because they just don't want to be on medication or they've had bad experiences and they just only walk into alternative medicine. And if you're seeing, patients that are overweight and have never really had a medical workup in a very long time, it's very likely that you may see some of these progressed diabetic patterns. Now, the other key thing you're worried about is diabetic neuropathy. Hyperinsulinemia, glycosylated end products can really destroy nerves and cause microvascular impairment to blood vessels, to neurons. And eventually, if it's not controlled, it can cause amputations and just tingling and numbness and pain. So if someone that has diabetes has constant tingling, pain and numbness or burning, those are signs that they may have neuropathy. So for the most part, with diabetic neuropathy, there's damage to the blood vessels of the nerves, and the nerves start to shrivel up. And then they go through this process of healthy tissue to then having the nerve and the blood vessels to the nerves starting to be injured to the point where they lose sensation, and then they can actually have some gangrene and significant dysfunction if it's not managed. And there's 2 different types of neuropathies. There's large fiber neuropathy, which impacts the myelin sheath, which is not as painful. It causes some numbness and tingling. The C fiber, where the inflammation against is non-myelinated fibers, causes significant pain and burning all the time. So with people that have diabetic neuropathy, there is either large or small fiber. Small fiber is much, much more painful and electric and thermal, and it really is horrible. Whereas a large fiber can cause numbness and tingling and weakness. So some patients, have both, but typically it'll be one or the other. And then these large fiber neuropathies or small fiber neuropathies, they usually cause the so-called gloves and stockings distribution. So it's just their hands and feet because it's impacting the blood vessels. So you see the expressions in the distal hands and feet. And also people that have diabetes end up getting lots of tissue swelling. They can get entrapment syndromes like carpal tunnel or ulnar syndrome or popliteal syndrome or femoral nerve entrapments. So they can get these mononeuropathy entrapments as well as these metabolic neuropathies. So you want to go through and do a really good inspection of their legs and feet and make sure everything's working well. You want to, when you're doing a inspection of their extremities, you're not only looking for ulcers, but you're looking for signs of neuropathy. So you look at their skin color, you look to see if their skin is shiny. That happens when there's lack of blood flow and innervation to their nerves or peripheral vascular diseases. Look for ulcers, see if there's any swelling, see if there's any calluses. Look to see if there's any deformity of their joints. You may want to even check their temperature, check the capillary refill time. And then you can do what's called a monofilament test, which is a test where you have a very small diameter filament where you touch their toes and see if they can feel it in a vibration sense. And usually if they have some type of neuropathy, you might see a broad base stance or a foot drop or a cautious gait. Let me show you a video of a diabetic exam, because this is something you should definitely do. And it goes into the monofilament test and inspection, everything as well. This is about 3 minutes. So just take a look at this video. So again, missing toes or limbs, look around, any walking aids, how they walk, how their gait is, their limb color.
Okay, I'm just going to check for any hair loss, any skin changes, any redness, or ulcers. Okay, and I'm just going to have a look between your toes then, it's alright? Okay, and I'll also check the bottom of your feet. That's great. Can you lift your heel up? And the other one? Brilliant. Okay, Dennis, I'm just going to have a feel of your legs now. That'll just involve me feeling down your legs and feeling the pulses. Is that alright? Okay. Okay, Dennis, I'm just going to have a feel of your toes now. I'm just going to press gently on the bottom of them. Okay, I'm now going to test the sensation in the bottom of your foot with this monofilament. It feels like this. And again, I'd like you to close your eyes and let me know if you can feel it on the left or the right hand side. Okay. Alright?
Right, left,
Okay, I'd like to test vibration in your feet now. And that's going to involve me placing this tuning fork on your feet with your eyes closed. I'd like you to tell me if you feel the vibration and tell me when it stops. Right? So it normally feels like this. Okay, alright? So close your eyes.
yep, and it stopped. Yep, and it stopped.
Okay, Dennis, I'm just going to test your sense of joint position now. So, with your toe, this is up, this is down. You can close your eyes and tell me whether it's going up or down.
Okay, up, down, down,
Brilliant.
up, down, down.
Okay, Dennis, I'd just like to test your reflexes now. So I'm just going to tap the back of your leg with this tendon hammer just gently. Is that alright?
Yeah, that's fine.
Okay. Could you just lift this knee up and flop your leg out to the side? Brilliant. I'd just like to watch you walk now. So if you could just come off the bed, and if you could just walk across in front of the bed for me. Okay, Dennis, start to me finish my examination. Would you mind if I had a quick look at your shoes just before you put them back on? Yeah, that's fine, yeah. Okay. Right. That's great. Thank you very much for letting me examine. No problem.
Okay, so a couple things. If you don't know what a monofilament is, any medical supplier has these monofilament tests. Some are disposable. Some are just like the instrument he used, just a very thin filament with a certain diameter. You just gently touch your skin, and you should want to see that bend. If it bends, then then that's enough pressure. And then you go through the toe pattern that they showed in the video, and you just want to see if they feel it or don't feel it. And really important to have the patient close their eyes when you do the test. And that's a big clue to that they may have some degree of neuropathy. It's one of the most sensitive markers to identify diabetic neuropathy. Now, you have to realize when you're doing vibration tests, and let me give you a clue how to find early signs of neuropathy. When you do vibration sense, the first thing you want to do is you want to take the tuning fork, hit it so it's vibrating, and then put it on their toes and see if they can feel it. Now, with people that have early types of diabetic neuropathy, one of the things you're going to see is that that they can feel it, but you should also compare it with their leg compared to their toes. So if you take a tuning fork and you put it on their, let's say, thigh or kneecap, or even on their shin, you should be able to perceive perception. And then you want to put it on their toes and see and ask them which one feels stronger to you. Now, what should happen in a normal response is that the toes should feel stronger because there's more proprioceptors there. So in early diabetic neuropathy, what they'll tell you is they can't tell that their toes are stronger than their legs, that they feel about the same. You can also see that with people that have really bad circulation as well. That isn't related to neuropathy, but be aware of that. So if you see someone that's starting to have cognitive decline and brain decline, when you do your tuning fork test for vibration sense, not only should you check to see if they have it or don't have it, but compare their distal tissue like their toes to their leg, and there should be more perception in their toes. And if it's not, that's a sign that they're losing or having some degree of myelin inflammatory responses. It has to be pretty progressed to the point they don't feel anything with vibration sense. Now, if they lose vibration sense and they lose proprioception of their joints, those are large diameter neuropathies. And if you can't touch them and their skin is shiny and they're in a lot of pain, they have a hard time putting on their socks and shoes, that's a small fiber neuropathy. The other key thing is that people that do have neuropathies that are large fiber, where they have lost proprioception, they're going to come in walking like they're in pain or they're injured. They have abnormal proprioception, and then definitely when you look at their shoes, they're worn improperly, and they may even have issues with falls and walk very slowly. And those are all clues to that they may have some degree of neuropathy. If you're seeing neuropathy in their feet, you need to know their brain is in trouble. Because basically what they have is they have myelin inflammation, they have myelin degeneration. What's happening in their feet is also happening in their brain. And vice versa. If you see early signs of dementia, you'll be more careful to look for demyelination in their peripheral tissues, because those glycation end product responses really damage these nerves, whether it's in the brain or the peripheral extremity. This is a typical checklist of how to go through the exam with your feet, but these are part of the complications. So once you start to see diabetes uncontrolled, high HbA1c for a period of time, you definitely want to go through your neurological exam very carefully. Now let's talk about some routine laboratory markers when you're looking at blood sugar disorders, and looking down to see how far along the downward spiral they have. So this is a pretty good panel to consider doing with routine labs. You may not include all these tests, but you definitely want to fasting glucose to see the severity of their insulin resistance. You want to do HbA1c and or fructosamine. Again, HbA1c 6 to 8 weeks of glycation. Fructosamine is 1 to 2 weeks of glycation. GlycoMark is a really good tool to look at their glycemic spikes over a period of several weeks, which tells you how well they're stabilizing the blood sugar levels. If you suspect they have glucose and insulin issues or postprandial responses after they eat that are pretty abnormal that you want to measure, they can do this glucose insulin response 3-specimen test. But realize this is not a fun test for their patient, because they go to the lab, they get a little Gatorade type drink that's very, very sweet. They drink that, and then they have to get this huge glycemic spike, and then they get their blood draw at baseline before the drink, 1 hour later and 2 hours later. But it's a really good test to see any postprandial responses. You should always have a comprehensive metabolic panel that measures the electrolytes, the creatinine, gene, total protein. They usually call these chem panels or comprehensive panels. Chem panel 14 is is generally the routine markers. Lipid panel to see how abnormal their lipid markers are from their dysglycemia. CBC with differential, again, to look at their immune health, especially if they have type 1 or you're worried about their pancreas cells not working, you look at C-peptide. C-peptide is a direct reflection of how much insulin they're producing. If their C-peptide levels start to drop, that means their pancreatic islet cells are not functioning, and you can definitely check some inflammatory markers. And then some functional medicine tests, again, adrenal cortex, cortisol panel, and then urinary glyphosates, and endocrine disrupting chemical, toxic, non-metal chemical profile, and then looking at the GI panel, are some pretty good routine markers. So remember, with insulin resistance, glucose can't get into the cell, so glucose goes into lipogenesis pathways. That's when you see triglyceride levels go up, total cholesterol go up, and insulin itself activates something called cholesterol ester transfer protein, which causes hypercholesterolemia. And then these glucose levels that can't get into the cell, if there's lots of inflammation, free radicals oxidize them, you can get glycosylated end products, and that can damage nerves and tissues as well. Here's the patterns for blood sugar patterns. Postprandial dysglycemia, you may have to do a postprandial insulin and glucose response to see those early signs. With early insulin resistance, glucose is greater than 99, triglycerides can go up. Once they actually get into metabolic syndrome, that's where you start to see their triglycerides elevated. Many times the triglycerides are higher than their cholesterol. That's like a hallmark. You can pretty much be certain that they have some type of metabolic syndrome when their triglycerides are above their cholesterol. But the criteria is there have to be 3 out of 5 markers or signs that they may have metabolic syndrome. Increased waist circumference, hypertension, glucose that's elevated, triglycerides that's elevated, HDL that's low. 3 or 5 of those signs indicate they have metabolic syndrome, which is basically prediabetes. And then you can also measure glycomark. I'll go over that in a second. That measures glycemic spikes. And then with diabetes, their glucose is above 126. And once your glucose is above 126, you know they're diabetic. And then you're really worried about their glycation markers. And you can measure things like HbA1c or fructosamine to see how progressed they are. Whenever you see HbA1c levels above 7, this is where all these things come into play. And the higher the HbA1c, the greater risk there is for diabetic neuropathy, retinopathy, eye troubles, and that could be cataracts, that could be scotomas, it can be eye movement muscle disorders where they get double vision, palsies, nerve palsies, kidney failure, heart disease, hypertension, stroke, peripheral arterial disease, wounds that don't heal, urological dysfunction, erectile dysfunction. And this is where really careful examination, routine blood work becomes really important for people that are really getting to that stage. Now, there's some laboratory tests that monitor glucose, and there's laboratory tests that measure glycation. Don't confuse the two. So sometimes people say HbA1c is a good marker to determine blood sugar stability over 6 to 8 weeks. That's not accurate. That's not what it's for. HbA1c is not there to measure blood sugar stability. HbA1c measures glycation, the combining of sugar with proteins, in this case red blood cells, as a marker of how much oxidative stress and this glycation response that they're having that then leads to complications and inflammation throughout their body. So the HbA1c is a 3 to 4 month window examination, and this is very predictive for diabetic markers, and we know that these levels have strong correlation with glutathione levels being depleted. And fructosamine is a similar test, except it's around the 1 to 3 week window, some say 1 to 2 week window of looking at glycation. So if you want to check for glycation more often, you want to use a fructosamine test. And then if you're looking at it every 3 to 4 months, you can measure the HbA1c. There's another great test that's available now that measures glycemic spikes. So this is the test that measures how well they're actually controlling their blood sugar fluctuations. These don't measure that. These measure how much glycation you have. The glycomark, which is 1,5 anhydroglycoprotein glutathione, is a measurement of hyperglycemia or spikes or exertions for the past 1 to 2 weeks. So remember, let's go over these tests with more detail. So this is glycation. This is HbA1c, red blood cells. They're exposed to glucose, and then glucose binds to the proteins of red blood cells, and that's what you're measuring with advanced glycation end products and HbA1c. And when you're looking at this HbA1c test, it comes in a percentage. The HbA1c test is a measurement of how many red blood cells have sugar attached. So HbA1c of 7% means 7% of the red blood cells have sugars attached to them, and that's pretty significant. And that's when you start to see complications. So here you see hemoglobin. When you start to get glycation, you get changes in red blood cell. Here's an illustration of that here, where you're getting these red blood cell proteins that are starting to have these sugar compounds bind to them. And when levels are above 5.7 or higher, you start to have patterns of prediabetes, and complications start happening usually around 7 or higher. So here you see 6.5 or higher is when you start to get some serious problems with them. Now, also note that your HbA1c levels can be less accurate if the patient has iron deficiency anemia, because what is this measuring? It's measuring red blood cells that are glycated, percentage of red blood cells. So if you're already anemic, this can be a falsely high. Any kind of blood loss can give you abnormal measurements, whether it's from menstrual bleeding, any type of anemia, or if there's blood loss, it can be falsely low. Sickle cell anemia or thalassemia can impact HbA1c. Liver diseases, kidney diseases, they can all impact HbA1c levels. So here's a chart that shows you how HbA1c levels correlate with blood sugar control. So you can see someone, for example, who has blood sugar levels of 170 typically has an HbA1c around 7. So there's some associations between high blood sugar levels and glycation. However, you can have someone who has blood sugar levels of 135 and HbA1c of 9 because they have significant inflammation. As a matter of fact, if you see that these blood sugar levels don't match in this chart like this, like you see glucose, but HbA1c is much, much higher, suspect significant oxidative stress, inflammation, chemical exposure, glutathione depletion, or mechanisms beyond just the hyperinsulinemia. Now, here's the basic symptoms, list of symptoms that are similar to diabetes with high HbA1c, but many times there's no individual symptoms other than chronic inflammation. So once people start to make glycation end products, advanced glycation end products, those actually bind to receptors called advanced glycation end products, and that causes significant inflammation throughout the body. And then these advanced glycation end products that go through this RAGE response can damage kidneys, damage nephrons, damage blood flow to nerves, damage arteries itself, cause arterial stiffness. That's where you end up with all these complications. So remember, the higher the HbA1c levels, the higher the risk for the complications of diabetes, retinopathy leading to blindness, nephropathy leading to kidney disease, neuropathy leading to amputations, microalbuminuria as an early state of kidney disease where the nephrons are injured. And then microvascular disease, the most common expression of that is little mini strokes all throughout the brain that leads to vascular dementia, and eventually they can get heart attacks or strokes and so forth. The key thing with these advanced glycation end products is when their kidneys fail, because once you make advanced glycation end products, the only way to get rid of them is the kidneys have to degrade them and clear them. That's why when the kidneys get involved, it's the most severe pattern. So clinical concept, the kidneys clear aids advanced glycation end products, and once HbA1c levels become elevated, careful monitoring for renal function should be done. And then another clinical pearl, remember, HbA1c levels can be elevated due to oxidative stress, not just hyperglycemia. Always investigate mechanisms of oxidative stress or inflammation when HbA1c levels are high. So fructosamine is very similar to HbA1c. It's just glycosylated albumin versus glycosylated hemoglobin. Here you can see fructosamine, which is glycosylated albumin compared to hemoglobin. This reflects the 1 to 3 window. And just like HbA1c, fructosamine has very high correlation with HbA1c, so it's a measure of glycation, but it's if you're going to testing more often. And here's a chart comparing the two, so they're both very, very similar with their findings. Now, a test that many people have not been using in their office that's come out in recent years is this glycomark test. And this glycomark test really determines how many blood sugar spikes they're having throughout the day. And these blood sugar spikes cause massive inflammatory responses and really stress out the regulatory systems. So all your conventional labs offer this glycemic test, and the way you run this test is you just order it, and then the results come in. And low numbers, anything less than 10 is abnormal. And the lower the number tells you that they're having many more blood sugar spikes and blood sugar fluctuations throughout the day. So when they have these extreme shifts of blood sugar levels spiking all over the place, that's when you'll see abnormal glycemic numbers. And this is a non-fasting test, so you can do it even if they're non-fasting. And it does not evaluate glycation like HbA1c or fructosamine. It just tells you how often the spikes are. Ideally, with someone who's diabetic, you want their HbA1c or fructosamine as low as possible, and you want their glycemic numbers to be above 10. And then there's just some information of comparing these tests, and then how they correlate with each other and how they're different, if you're looking at those. So here's a glycemic test, for example. It'll tell you the example of an outcome. It just gives you the numerical number, and then it gives you a scale, and you can get an idea of how that correlates with their blood sugar control. And looking at someone with glycemic, you should always also look at HbA1c. So if you look at this person, HbA1c is really high, 7.1, so they have risk for complications. And look at this glycemic, it's below 10, it's at 3, it's pretty low. So that means that they're having glycation and their blood sugar spikes are all over the place. So they're not doing a very good job with their diet. So as you go through your clinical evaluation, you're going through each of these patterns, and you're trying to determine if they have postprandial issues with insulin spikes. We went over this chart and showed you examples of postprandial response. You have to do a postprandial fasting test for those, either a 1 hour or 2 hour test. You have patients of insulin resistance where their glucose is above 100 but less than 126. And this is the chart I gave you that goes over the laboratory patterns. And then here's a sample of that. Glucose is elevated, but not above 126, and triglycerides are also elevated. Then as you get into metabolic syndrome, remember 3 of the 5 symptoms, blood pressure that's greater than 130 systolic, greater than 130 over 85, fasting blood sugar greater over 100, waist larger than 40 inches for men, 35 inches for females, HDL cholesterol less than 40 for men and 50 for women, or triglycerides over 150. Here's an example. Here you see glucose levels high, triglyceride levels high, HDL levels that are low. So they have 3 of the 5 findings for metabolic syndrome in this example. And the metabolic syndrome is typically associated with promoting things like polycystic ovarian syndrome for infertility and risk for stroke and promotion of neurodegeneration. So those are key mechanisms to look at when you have those types of diseases or chief complaints in your office, and they're trying to look for dietary lifestyle approaches. Now, once they get past this 126 fasting glucose level, like here you see a fasting glucose of 145, this is now, they've entered this diabetes realm. And now you're really worried about things like HbA1c. So in this scenario, they have diabetes, but they don't have much glycation, which is great. At that point, you really want to make sure this stays below the 5.7 range, as low as they can keep it. This is a chart for the symptoms when they start to progress to that area that you have in your notes. And then once they start to have their HbA1c elevations, that's when they have this glycation response. This is where all the complications happen. This is where they get severe inflammation. This is where blood vessels get destroyed, organ tissues get destroyed, inflammatory responses take place, arterial stiffening, complications. The higher the number, the greater risk they have for these conditions. And here, like you see an example of a patient, glucose is 185, HbA1c is 5.9, so now you're dealing with a more severe type of diabetes. They're now dealing with all the complications. You want to do a very careful examination at that point and make sure there's no complications. And then if they progress, they'll start to have complications in tissues, whether they'll have pins and needle issues from like a neuropathy, or they start having scotomas or retinopathy, or they start having microvascular disease or strokes. This is a chart I made for you guys in this course that teaches you how to look for the symptoms for each one of these complications. So once you see HbA1c levels high, make sure they don't have any symptoms of their feet tingling or numbness or burning nerve pain. Make sure they have no signs of light sensitivity, blurred vision, fluctuating vision, impaired color vision perception, visual scotomas, areas where they don't see things very well. You might have to test for that specifically. Make sure they don't have foamy urine. Make sure they don't have any signs of cognitive decline. You might want to do their ankle-brachial index of blood pressure. Make sure they had no indications of any past TIAs or that any abrupt loss of function. And then you always want to at that point check their C-peptides, see if they're producing insulin and if those levels are going down over time. If you get a C-peptide test and their levels start to drop over time, that means their beta cells are getting worse. And you really want to make sure that HbA1c never crosses that 9% line, because that's when things get really bad very quickly. And then if they progress and they start to have renal damage, nephropathy, and this is where they really get to the point where prognosis is really, really bad. Blood pressures get worse. Since their kidneys aren't working well, they can't get rid of albumin, so they get swelling in their feet and ankles. They even come out with swollen feet and ankles. They get persistent itching. Kidneys are involved with different chemical agents that then lead to itching. So it's really common chronic itching and swelling in their feet. They can have mental confusion. And then on lab work, you definitely want to get urinalysis, look for proteinuria, see any of the kidney markers that are abnormal. Here's a list of them. And then you remember just the key functions of the kidneys. I made together some markers for you if you don't remember the laboratory markers for evaluating renal function. So these are the serum markers on a basic test, and these are urinary markers that you typically want to run. If these are abnormal, you want to make sure you have a nephrologist involved at this point. And if they start showing up signs of kidney disease, stage 1 is when their GFRs are elevated than 90 and there's proteinuria. Anytime you see proteinuria with a high eGFR, you need to have a nephrologist on board. And then once they get into stage 2 and above, that's when they may actually have to do dialysis. And here's the bad news. Majority of patients that end up with dialysis with type 2 diabetes usually don't make it to 5 years. They usually have complications or a stroke, and this is where things get really, really ugly. So remember that once the kidneys are not able to do their job and get rid of proteins, blood pressure levels go up, they can't get rid of the advanced glycation end products. I put some other laboratory markers for you in your notes just to how to evaluate urinalysis and kidney markers and lab markers to just help you if you need to review them. There's also a test if you suspect early liver kidney disease before they show up with kidney failure, or they have lots of foaming in their urine. You can do a microalbumin 24-hour urine collection. And if those levels are abnormal, then they're starting to get early kidney disease. This is what they start to look like. Glucose levels can change. Kidney markers, GFR levels are low. And then if you look at their urine levels, they're abnormal. This is a person that has, kidney disease. And if we take a look at that, GFR 30. So this person's, progressed down the scale of kidney disease to the point where they're in stage 3. That patient needs dialysis. I'm going to go over this specific patient with you because it's in the case study as well. But those are, the things you have to think about when you're looking at kidney disease. Once you get kidney disease, that's when you lose the ability to clear out advanced glycation end products. So high HbA1c with kidney disease, it's just a matter of time before a massive stroke or kidney failure or something happens, which is always terrible. Now, the other things you want to do with just people that have insulin resistance diabetes, when you do functional medicine testing, you want to eventually look at chemicals. You want to look at their gut. You want to look at chemical immune reactivity, glyphosates, sample reports. These are important tests. They may not be the first area of treatment, but these are tests that you really want to make sure that you have in your tool bag to look at the obesogen and toxic chemical exposure response. And then, of course, a GI panel. We talked about this extensively in the GI course, GI module. We'll review some concepts as well later and make sure they don't have leaky gut or intestinal permeability. So you can also evaluate some intestinal permeability tests. And the other key thing to definitely look for with patients that have insulin resistance, especially in females that are overweight, is gallbladder issues. They have high risk for that, more so in females than males. And bile salts are really critical for controlling the modulation of the gut microbiome through FXR receptors and incretin release to control receptors as well. So in summary, this is the chart to how to evaluate patients with dysglycemia. You go through initial clinical survey, you get a visual evaluation, what their weight is, the overweight, underweight, normal weight. You do the medical history, see if they have chief complaints of blood sugar disorders. You get an idea if they may have a tendency to be hypoglycemic, hypoglycemic from lifestyle and diet, hypoglycemic unrelated lifestyle, maybe some underlying metabolic disease, or insulin resistant due to lifestyle, or even diabetic related to autoimmunity. Those patterns of diet and outcomes don't match with each other. And then you go through physical exam, and you definitely want to do a BMI, check their body composition, and then look at the skin for findings of hyperinsulinemia, do a cardiovascular exam, especially blood pressure, hypertension, anchor-brachial index, look at their eyes, make sure they don't have any microvascular disease, don't have any cataracts, do a neurological exam, diabetic foot exam, make sure they don't have any diabetic ulcers or neuropathy, and then do your routine labs to get an idea of their degree of glycation and how severe they are in their blood sugar pattern. And when you're done with your exam, you should be able to determine if they have hypoglycemia, autoimmune diabetes, or insulin resistance, and where they are on the severity scale. And finally, the clinical pearl. After the clinical evaluation, you must determine two things. Number one, what is the severity of their condition to determine if referral is needed for management, testing, etc. Number two, the severity also establishes case prognosis. Like for me, I don't work with diabetic patients that have nephropathy. If they have kidney disease, they're out of my office. I don't recommend any supplements. I don't do anything for them because there's too much risk of complications. So also, if I see a blood sugar level below 65, I definitely need other people on board to figure out what's going on. So, part of doing your functional medicine workup is to see if they're a candidate for diet lifestyle medicine care now, or if they have something that needs to be ruled out first. And then the other thing you must do is make a list of subjective and objective examination findings in order to properly monitor the patient during the clinical evaluation. So when you're done, you can make a list of, hey, here's an example. Here's your main symptoms. Here's your abnormal lab work. Here's the exam findings. So maybe fatigue after meals, chronic pain, inability to stay asleep, hair falling out, depression, fasting glucose is 146, HbA1c 7.9, CRP is 9, and then skin tags, weight's 220, BMI is high, blood pressure is high. And then everything you do is then compared against this for this patient. So your baseline and then over time. So those are the key things to do when you evaluate a patient with dysglycemia. Next section, we're going to go over how to manage these patterns. So we'll go over that next. Thanks.